Sugan from Wockhardt medical team. And thank you so much, everyone, for sparing time out of your busy schedule and for waiting patiently. And very warm welcome to all of you for entire Wockhardt team and for this much anticipated iTrust webinar. It is with great pleasure and enthusiasm we come together as a community of dedicated professionals to explore so the topic for today's webinar is continuous glucose monitoring for monitoring blood glucose level with specific focus on time and range. And I'm honored to extend my heartfelt welcome for esteemed faculty member, Dr. Gautam Krishna. And with the help of Dr. Krishna's insightful discourse and his knowledge on this vital topic, we anticipate that we'll get better understanding of CGM to get better understanding in optimizing patient care, fostering a more nuanced understanding of challenges surrounding glucose monitoring, and ultimately improving the quality of life of patients living with diabetes. So, as we embark on this knowledge sharing journey, I encourage all of you to actively participate in this thought provoking discussions and leverage this opportunity to expand your understanding of the advancements in continuous glucose monitoring, thus enabling us to make significant strides in the management of diabetes. Towards the end, we'll have Q&A session followed by vote of thanks by Wockhardt marketing team. So, today's speaker is Dr. Gautam Krishna Magnam. He's a consultant general physician. And just a brief introduction about Dr. Gautam Krishna. He is a consultant general physician at Kakinada Inodaya Hospitals. He had been senior resident for about a year at Kakinada. He completed his MBBS from Kakinada and MD General Medicine from Vizag, Andhra Medical College. He has certificate course in evidence-based diabetes management, and he's got several research paper presentations and has been a speaker in several CMEs. And now, without further ado, I'll pass the mic on to Dr. Gautam and waiting to get some meaningful insights from him. Over to you, Dr. Gautam. Dr. Gautam, would you like me to present? And you just let me know. I'll just keep changing the slides as and when you want.
Dr. Sugandha, Dr. Gautam is facing some problem. So
okay. We'll have to hold on for some more time.
We have to hold on for some more time.
Okay.
Dr. Gautam has joined. Welcome, sir.
Yes, hello.
Yes, sir, we can hear you, sir.
Welcome, sir.
Yes.
Welcome, Dr. Gautam. Thank you so much.
Yeah, thank you. Thank you and sorry for, am I visible clearly?
Yes, sir. Yes, sir, you're visible and you're audible as well.
Okay.
Yeah. So do you want me to present the slides and I can just keep on changing? Will that be okay?
Yeah, that will be fine, yes.
Okay.
So shall I go ahead?
Yes, sir, please.
Yeah, thank you. Thank you. Thank you. Yeah, thank you very much. And good evening to all the listeners, all the doctors. So the topic is about the continuous glucose monitoring. So technology in the management of type 2 diabetes, present status and future prospects. So technology in the management of type 2 diabetes has evolved so much that we have very advanced tools in our hands to in case of either monitoring or in the treatment aspects of diabetes. So if you look at this slide, we have in the management of diabetes, we have the improvement in HbA1c, which we always try to achieve the target HbA1c in all our patients. And the other thing is the reduction in hypoglycemia. So hypoglycemia, which is a very dreadful condition for the patient, and which is capable of doing a lot of harm to the patient, is one thing that we always are worried about in the management of diabetes. We always try to reduce the risk of hypoglycemia. And the other thing is the improvement in the quality of life. So what we all are trying to achieve in the treatment of diabetes is to reduce the long-term complications and thereby the quality of the life, which is very much badly affected because of various things like the cardiovascular complications, like the coronary artery disease or the cerebrovascular accidents, or the other organ involvements like the renal and the retina involvement and the peripheral neuropathy. So a lot of severe comorbidities, severe complications that we get on a long-term basis because of poor diabetes management. So these are the three things which we always try to address. One is we measure the HbA1c, which is the main monitoring tool that we routinely have to know the glycemic status of the patient, how well is the glycemic control of the patient. So we always try to bring the HbA1c to the target range of around 7 and less. So HbA1c is an important thing that we always try about, and then the reduction in hypoglycemia and the improvement in the quality of life. So how does the technology will help in managing all the three things? So we have what we call as the continuous glucose monitoring system, where we continuously monitor the glucose. We have devices which can monitor the glucose very frequently, and can present and can give us very good information about the glycemic control. And this is a major advance in the management of diabetes. So far, we are so much relied upon the HbA1c to know the mean glucose values over a period of 6 weeks to 3 months. And now we have a very good measuring variable, which is the continuous glucose monitoring. We have various variables in the CGM, which include the time in range. We have the smartphone apps. We have the closed loop systems, which includes a continuous glucose monitor and as well as an insulin pump, continuous insulin pump. And we have smart insulin pens, we have smartphone apps, and the AI as well in the advanced management of the type 2 diabetes. So this is the future prospects that we have. We have very good systems in place to measure the glycemic control of the patient, and we have very good system in place to reduce the risk of hypoglycemia, and thereby in the long term we improve the quality of life. Next slide, please. So how do we looking at the parameters of glycemic control, which we have the HbA1c all the way in the year 1966. It is identified the HbA hemoglobin A1c, and later on it came into use for the monitoring. In 1993, in case of type 1 diabetes, in DCCT study, it is established as a good variable, good clinical marker for glycemic control. And in the year 1998, the UK-PDS study which has established the HbA1c in case of type 2 diabetes as a good clinical marker for the glycemic control. And then the advent of the continuous glucose monitoring, we have in the year 1999, where the time in range variable has come into the picture. So the time in range is actually means the amount, the duration of time a person spends in a specific range of glucose. Like for example, between 70 and 180 milligrams per deciliter. So the amount of time, the percentage of time an individual spends in a specific time period in a specific glucose range is what we call as time in range. So this came into picture in 1999, and in year 2000, 2017, the clinical consensus has made international consensus was formed for the time in range and how to use it, and how to determine the time in range, and etc. So HbA1c, we have moved on from HbA1c to time in range. And so we rely on both these factors to know the glycemic control. Next slide. So HbA1c reflects average plasma glucose over the previous 8 to 12 weeks. So HbA1c is a reliable marker because it is a gold standard marker so far, and every 3 months we rely upon the HbA1c, and it's a gold standard for assessing the glycemic management. It has been used as a biomarker for more than 3 decades, currently used for both the diagnosis and management of diabetes. So we mark more than HbA1c more than 6.5 as the diagnosis of diabetes, and we have a target of target HbA1c of 7% in most of the individuals we target, and in case of elderly and in case of comorbidities, we'll target a higher HbA1c. And so this is how the test is easy to administer and cost effective and relatively inexpensive. So this is about the HbA1c. Next slide, please. So a quarter of a century ago, the DCCT established the importance of HbA1c. So it is the glycated portion of the hemoglobin that we measure. So through certified methods, we have the HPLC method and other NGSP certified methods for measuring the HbA1c. And this graph shows the relation, the association between the HbA1c and the microvascular complications. Look at the retinopathy and nephropathy, which stands more in relation with the HbA1c. So this trial has established actually the HbA1c has a clear-cut association with the microvascular complications, which include the retinopathy, nephropathy, and neuropathy. So this is about the DCCT trial and the risk of complications. Next. So what are the limitations of HbA1c? Even though HbA1c appears to be a good marker of the risk of diabetes complications and mortality, it does not represent a comprehensive view of an individual's glucose profile and its variations. So far we think that HbA1c is our target, but actually it is not. There are a lot of fallacies, a lot of false reassurances with HbA1c. In fact, because of various limitations that we are going to see in the next slides, the HbA1c has its own limitations. And next slide, please. So we look at this slide. We look at the two patients here whose HbA1c is 8%. If you look at the patient 1, we have a high glucose variability with episodes of hypoglycemia and hyperglycemia. The HbA1c is actually a mean glucose value that we are measuring, and if you see when there are wide fluctuations, wide excursions of glucose, like in hypos and hypers, we actually get a HbA1c. We think that it is okay, but actually, if you can see in the second slide, HbA1c of 8%, but there is low glucose variability. So the second patient has less risk of complications because he has less glycemic variability. So this picture, which will be masked when we only look at the HbA1c. So that is the reason why we are shifting towards the continuous glucose monitoring to know these highs and lows of glucose. Next slide. So yes, and the other things that we know which affect the HbA1c or the anemia and the accelerated erythrocyte turnover, thalassemia, sickle cell disease, reticulocytosis, HIV infection, uremia, and then dyslipidemia, cirrhosis, hypothyroidism, and then physiological states like pregnancy, and then medical therapies like blood transfusion, hemodialysis, and various drugs will affect like the aspirin, the alcohol, and the miscellaneous conditions like protein turnover. So a lot of conditions will actually affect the HbA1c. So this is the reason why we used to rely on, along with HbA1c, we also ask the patients to get their home self measured blood glucose as SMBG values. So every week I ask my patients to measure their values at home, the fasting and the postprandial value, and to record them in a book, so that we can correlate between the HbA1c and the measured values at home. So this is very vital because a lot of factors can affect the HbA1c, and we cannot effectively rule out all these factors in all our patients, and therefore we cannot be assured by the HbA1c because of all these limitations. And definitely we have to ask. This is the reason why we have to ask the patients to get the fasting and postprandial as frequently as they can do, like once a week or twice a week, so that we can correlate between the actual values and the HbA1c. And also, we also ask our patients to check their sugar values at different times of the days. So one day they'll check post lunch, and one day they have to check post dinner. So we have to check different kinds of different values at different times of the day. So this, and we have to actually confirm the correlation as well. Next slide, please. So same HbA1c can hide differences in target range. So this is a slide which shows the continuous CGM report, which shows the excursions of glucose over different days. If you can see, for this patient, the HbA1c is 6.7%. But look at the graph. Patient is almost 50% above 200. And 30% around 250, and the patient is also experiencing hypoglycemia, sugars less than 70 for a significant amount of time, and but this patient HbA1c is 6.7%. So once we see the 6.7, and once we see some random values coming normal, we think that this patient is under a very good control, but actually we are missing a very bad glucose control, only which we can get by the continuous glucose monitoring. Here, the CV means the coefficient of variation, which is actually the variation of the glucose from a mean value. So this is 53% of variation from the mean value, and this coefficient of variation is actually an indicator which we have to keep it below 30% for an optimal glycemic control. And here this graph is showing 53% of CV variation, and still the HbA1c is well under control. So this is a clinical picture. In clinically, if we can, this kind of graph will be seen in patients on high dose sulfonylureas, where they'll have hypos and hypers, and still they'll have HbA1c of 6.7%, and they are happy, and the treating physician as well will be happy looking at the HbA1c. Next slide. So this is the target range, or the time in range of 70 to 180. In this is another patient where the CV is 42%, and still the HbA1c is 6.7%. So a lesser variation compared to the previous picture, and that is how the HbA1c will present a false reassurance for us in spite of a lot of variations here. Next slide. So same HbA1c can hide differences. So again, the third patient, if you can see here, the coefficient of variation of 26%. You see the graph, almost 90%. He's 95%. He's on. I mean, he's in time in range. Time in range is very high. So he's almost having no hypoglycemia, and he's having very few values more than 200 to 250. So the variation is 26% is optimal, and the A1C is 6.7%. So this only we can get through the CGM. Next slide. So HbA1c does not tell the full story. So that's what we are getting about these through these pictures. Time and range can be very different at the same HbA1c. So we have three examples here, and all the three have the same HbA1c of 7%. If you look at the example one, the 58% of hyperglycemia and 24% of hypoglycemia. You see, and the example two, we have 29% of hyper and 8% of hypoglycemia. And example three, we have 100% of euglycemia or target time in range. So that all the three have same HbA1c. So that is the reason why the HbA1c will not give us a full picture of the glycemic control. Next slide. So using HbA1c alone to assess the glycemic control can be misleading. So you look at the graph on the right side, you have a wide range of mean glucose concentrations can be associated with a given HbA1c level. If you look at the 7% HbA1c, so the glucose fluctuations can range from 200 to almost 100, so almost below 100. So there are wide variation in the with the HbA1c. A person can have a very wide glycemic variability with the same HbA1c, and so it is very misleading. Next slide. So monitoring the glycemic control, continuous glucose monitoring. So actually, this is a device, a sensor is having the electrode, which has a tiny wire made up of silicon or gold, send signals to the transmitter. So we have some enzymes which have glucose oxidase, converts the glucose to peroxide, and peroxide produce electrons from peroxide converted to electrical signal correlating to glucose. So we are actually measuring the interstitial fluid glucose levels, and this is a chemical to electrical conversion of the signal, and this is being continuously monitored. So this is how the actual mechanism of monitoring of glucose happens in the CGM devices. Next. So current commercially available CGM systems, we have we have three kinds of systems. Actually, we have real-time CGM, which actually measure the glucose and send to the device at the same time, and we can have a real-time glucose values reflected in our devices. So it provides continuous data on sensor glucose trends and alarms to the CGM receiver or the smartphone. So we actually get a real-time data in our devices with the real-time CGM. And the other one is the intermittent scanned type of CGM, where we have a sensor which is placed already placed, and we'll take the device and scan the device to the near the sensor, and we'll get the value over the device. So this is an intermittent scanned one. Actually, it will present us the last 8 hours of the data will be transmitted to the device, but you have to scan the device and scan the sensor with the device. This is called the intermittent scan type. And the other one is a professional CGM, where we actually insert the sensor to the patient. We'll register the sensor in our device, and we send the patient to the patient home, and we'll ask the patient to register all the daily the diet he have for the all the 3 times a day and all the time and the diets. And then we ask the patient to come back after 2 weeks, and then we'll take the data and all the 2 weeks data every day. All the data will be available and then we can we can know what actually is happening and how and where we have to intervene. So that is a third kind of CGM, which is a professional CGM. So these are the three kinds of CGM. We have different kinds of devices available. The Freestyle Liber is widely available here, and it's a very good device. We have easily available, and we have Eversense. So this is a most advanced kind of the CGM system. The Eversense is recently approved by FDA. So which is we have this sensor which is actually we can implant it in the subcutaneous space, and is it's completely invisible, and a small device will be a patient has to wear whenever it's needed, and that device will continuously measure the glucose for a period of 6 months, and that is very beneficial. So once in 6 months you can for 6 months it is available. It will continuously measure the glucose, and then we have the Medtronic and the Dexcom. These are the various CGM systems available. Next slide. So these are the differences between the HbA1c and the time in range by CGM. So HbA1c evaluates the single value, and time in range evaluates continuous glucose levels, and A1C compares every 3 months, but TIR at any time compare any time periods. So A1C does not capture hypo or hyperglycemic, which is very well shown in case of time in CGM. Immediate effects of therapeutic changes not recorded. So in time and range, we can know how our therapies, how the insulin adjustments, how patient diet and exercise are actually affecting the glucose values, the trends, and everything can be known in the time and range. But we have to wait for 3 months to know the effect of even to effect of the change in the diet or exercise or the drugs. And then comes the bad correlation to the patient-reported outcomes, and good correlation in case of time and range. Then high susceptibility to interference with the case of A1C, and time and range is very low susceptibility to interference. And the endpoint correlation is good with A1C. And also, and here the long-term studies are underway for the time and range, but it is very promising, and a lot of studies already have established time and range as a very good clinical marker. Next slide. So it's time to move on to HbA1c to time and range. So this is the most advanced kind of glycemic monitoring. We cannot miss these patients who have poor time in ranges and poor high glucose excursions and the hypoglycemias, and all these things we cannot afford to miss by looking only at the HbA1c. So we need to look at the prevention of the complications. All those things can be met by time in range. So it goes beyond even seen representing the glucose value levels, because it captures the variations, the highs, lows, and in-range values that characterize life diabetes. So it makes the management of diabetes to a newer level. It makes more easy for the patient as well as the physician. Next slide. So the world is changing from HbA1c to time and range. So different countries move at different rates with regard to the implementing these changes. We have to utilize this CGM devices in bringing about a lot of for our patients. We can do a lot of good for our patients by bringing this CGM. Next slide. So time in range refers to time spent in an individual's target glucose range, which is usually 70 to 180 milligrams per deciliter. Next slide. Next. Percentage of time spent below or above range indicates hypo or hyperglycemia respectively. So when we say about time above range is hyperglycemia and below is hypoglycemia. Next. So it may be used as an appropriate endpoint in clinical research and as a measure of glycemic control in patients with diabetes. So this is a newer variable that we have to look at. We have to choose our patients carefully, and in whom we think that there is a high chance of glycemic variability, like in case of people using multiple insulin device, multiple insulins, and and people who are more having a history of hypoglycemias, who are having hypoglycemias, and who are who are at high risk of complications for hypoglycemia. So a lot of patients we have who needs this continuous glucose monitoring and time in range. Next. Emerging evidence suggests that time in range is inversely correlated to risk of developing both microvascular and macrovascular complications in patients with diabetes. So to reduce the risk of complications, both micro and macrovascular, we need the time in range. Next. So this slide shows the relation between time in range and microvascular complications. If you look at the retinopathy and microalbuminuria, and for each 10% less time in range, retinopathy progression increased by 64%, and in case of microalbuminuria, outcome increased by 40%. So there is a very good correlation between the time in range and the retinopathy and the microalbuminuria. Next. So association of time in range with diabetic retinopathy in type 2 diabetes. So we have three different kinds of retinopathy, which is the first one is a mild one, then the moderate, and the vision threatening diabetic retinopathy. So if you look at the three graphs, the more is the time in range, the less is the prevalence of diabetic retinopathy, whether it is a mild or moderate or a vision threatening retinopathy. So in all kinds of diabetic retinopathy, we have to target a good time in range. So time in range is what we target is more than 70% of time in range is the target in most of our patients. In case of elderly or in case of people who are at risk of hypoglycemia, we'll target a less range of around 50 to 60% of time in range. Next slide. So coming to the macrovascular complications and the risk of and the relation with time in range. So we look at the carotid intima media thickness and the time in range as a relation. The first slide shows the prevalence with of the carotid intima medial thickness and the time in range. And we can see here more than 80% of time in range, and we have significant reduction of the CIMT. And then the second slide, the second part shows the prevalence of abnormal CIMT according to HbA1c categories. So likewise, the HbA1c also has a correlation between the CIMT and the time in range. So time in range obviously has a good correlation. Next slide. So what is the ADA consensus on CGM? So when used properly, real-time CGM in conjunction with multiple daily injections and continuous insulin infusion pumps, other forms of insulin therapy, are a useful tool to lower or maintain the A1C levels and or reduce the hypoglycemia risk in adults and youth with diabetes. So this is the ADA consensus. So which the CGM is basically addressing the good glycemic control, preventing hypoglycemia, and reducing the risk of complications. Next slide. So coming to the microvascular benefit and the time in range, if you look at this graph, the study shows the time in range below of 10% more time in range less time in range will cause 64% more risk of retinopathy and 40% more risk of nephropathy. So we know that in the DCCT trial, we have seen the lesser the HbA1c, the less is the risk of microvascular complications. So there is a very good relation between HbA1c and microvascular complications that is proven. And the same thing that we can also see here, where we look at the time in range and the microvascular benefit, there is a tremendous correlation between the time in range and the microvascular benefits, even in the progression of retinopathy or the nephropathy. So there's a good correlation between the time in range and the microvascular benefits. Next slide. So coming to the macrovascular benefits, we have already seen regarding the carotid intima media thickness. The time in range is associated with CIMT in large sample of patients with type 2 diabetes, suggesting a link between the time in range and the macrovascular disease. So 10% increase in time in range decreases 6.4% lower risk of abnormal ICMT and thereby the macrovascular complications. Next slide. So how do we compare the CGM with the SMBG, the self-monitoring of blood glucose, which we routinely advise the patients? So there is a good correlation between both the two, and the use of CGM in type 2 diabetes is beneficial as it significantly reduces the A1C compared to the usual method of SMBG. So the self-monitoring is always it is good, but it is most of our patients, very few of them will actually have a regular SMBG values at their home because of various things like the painful nature of the SMBG and the frequency of SMBG and a lot of things, a lot of motivation is required from the patient side, and a lot of time we have to spend to get the SMBG values, and often we do not get these SMBG values. So CGM is almost more. If you look at this graph, the CGM is more favored than the SMBG because of various reasons, and therefore we can have the CGM in place of SMBG in specified individuals. Next slide, please. So what are the Indian consensus guidelines on CGM for the clinical applications? So to monitor hypoglycemia, particularly the occurrence of nocturnal hypoglycemia, so we have a very good report of what's actually happening in patients. So patients often suffer nocturnal hypoglycemia and nocturnal arrhythmias, which can cause sudden cardiac death. Most of the patients on beta blockers, patients with cardiac diseases, so they are at very high risk of complications, and this is a dreadful condition, hypoglycemia. Remember, with all effort we have to avoid the hypoglycemia. So CGM will play a very key role in the newer devices actually warn us with a signal that your glucose levels are on the margin of around 70, or it is the trend is like dropping, and you are at risk of hypoglycemia. So it warns us to actually take a corrective measure to prevent further hypoglycemia. Most of our patients are patients who are frail, who are sick, or who are chronic diabetics, who are having autonomic neuropathies. So there it is very vital. And then to create a patient-centric treatment plan and to enhance the treatment compliance. So what actually the CGM does is it actually gives information straight to the patient. What is actually happening throughout the day? Where actually is the glucose levels getting higher? Where actually is the patient getting hypoglycemia? So by looking at those graphs, the patient can actually increase the diet or increase or reduce the calorie content of the food, or do some exercise, or so he'll get the motivation required. He will directly see the benefits of doing an exercise or the CGM, how the exercise is improving his glucose levels. So it is a patient-centric treatment plan can be devised by the CGM. So it reflects the characteristics of glycemic variability comprehensively and can reliably access intra and intraday variability. So interday and intraday variability can be reliably, the information we can get by the CGM. So to detect the blood glucose changes relating to factors such as lifestyle, diet, and treatment response. So how much insulin that should be given for a specific diet, and what is the kind of insulin and dosing that is required. So everything can be adjusted by the CGM reports. Then to demonstrate the postprandial hypoglycemia, asymptomatic nocturnal hypoglycemia, the dawn phenomena, and the somnogy phenomena. So all these things can be addressed by the CGM. Next slide. So we look at the specific groups of categories of people with diabetes. In case of type 1 diabetes, it is enormously important. CGM is enormously important because we often see patients with type 1 diabetes with poor HbA1c because of various factors like because of their age, because of their dietary habits. They always have hypoglycemias and the hyperglycemias, and it is very much recommended for type 1 individuals too, because they are mostly on basal bolus regimen of insulins, and they have to titrate the insulins with their carbohydrate content, which is a very difficult procedure, difficult process actually. And most of the type 1 diabetics we see having poor control of their A1C, and because of various reasons. And definitely indicated in type 1 pediatrics, it is also strongly recommended because you cannot do multiple pricks for pediatric age group individuals, and you cannot definitely record their values. So CGM is a very good option for type 1 pediatric individuals. Then type 2, in your type 2 diabetes, actually people who are prone for hypoglycemia, like people who are using on high dose sulfonylureas, people who are experiencing hypoglycemias, people who are on multiple insulin basal bolus regimens or insulin premixed insulins, they are having a very wide fluctuations with premixed insulins, and this is very strongly recommended. And then type 2 with low risk of hypoglycemia based on treating physician's discretion. So if a person who is not on sulfonylureas, only on metformin or SGLT2 inhibitors or the DP4 inhibitors, are not at risk of hypoglycemia with a good A1C control and good self-monitoring blood glucose levels, I think in those individuals we can avoid the CGM because of its cost and everything. And then in case of gestational diabetes, so this is another category of diabetes where we have to be very, very strict. Where we have a very good control. We require very good control to prevent the congenital birth defects and everything. And in case of diabetes, we require a very strict glucose levels, and the patient needs to be on insulin, and this can be used as a teaching tool to evaluate the glucose patterns, to fine-tune the insulin dosing. So these are the individuals where we we have clinical applications for the CGM. Next slide. So who benefit from CGM? So persons who have an increased risk or experiencing hypoglycemic episodes. So all the coronary artery disease patients, all the congestive heart failure patients who are elderly, who are frail, who are at risk of falls, who are using multiple insulin regimens, who are using premixed insulins, who are having a poor HbA1c control, and then individuals who desire increased engagement or information regarding daily, who are patients who are motivated, who wants to have a perfect levels of glucose values. So all these individuals benefit from CGM. So it helps to identify areas of glycemic values outside timing range to address current and future therapeutic options. So we look at the CGM, we know when does the patient is having hyperglycemias. So at what time the patient is having postprandial hyperglycemias. So at what time patient is having hypoglycemias. What alterations we can do with regard to the sulfonylureas or the insulin, or what kind of insulins we can use, what kind of whether you go for a basal bolus or a premixed insulins or a basal plus insulin. So the different kinds of options can be streamlined with the data that we get from the CGM. Next slide. So to summarize the presentation regarding the continuous glucose monitoring, so HbA1c may not be a good indicator of an individual patient's glycemic control. So there are numerous limitations with HbA1c. If we are using HbA1c as a monitor, as for clinical monitor for glycemic control, we have to definitely ask the patient to get a self-monitoring of blood glucose levels at different times of day, and we have to get the data, and then we have to correlate HbA1c. We have to see about all the limitations, the anemia, uremias, and the cirrhosis of liver, etc. And a lot of conditions we have to be careful when we think about HbA1c. And then understanding and using the CGM generated glucose profiles and patterns are critical to managing diabetes and titrating therapy. So CGM is the the standard of care for today's diabetes management, whether to know the glycemic control of the patient and to motivate the patient, to tell the patient to adjust the changes with regard to the data, and to produce good time and range and to improve the quality of life, to reduce the hypoglycemia. So to address all these things, we can have the CGM, which is very helpful for us and for the patients. CGM is a great tool to use as a team to help manage diabetes. So it, in partnership with the patient, physician can tailor the treatment of diabetes and to improve the quality of life, to prevent the complications, and to ease the to ease the management of diabetes. The continuous CGM is a very great tool in our hands. So thank you very much.
Thank you, sir.
Thank you so much, sir, for such a thought-provoking and informative session. And I'm sure with with these takeaways, it will be very beneficial for our clinicians in improving the life of the patients living with diabetes. Now, the forum is open for questions. Uh, Feel free to type your questions, and we'll take it up from here.
I think there are no questions. Everything is clear with participants.
Yeah.
Yeah. So I think we can go ahead and before proceeding towards, I would like to share few great news with the forum that I will just share my screen. So first of all, thank you very much, sir, for such a fantastic session. And I would like to share a news with all of you that Vosulin, which is India's first indigenous human insulin, has completed 20 years. So in 2003, we launched insulin, which was manufactured at our biotech plant situated in Aurangabad. And that biotech plant was inaugurated by Dr. APJ Abdul Kalam. And after the launch of Vosulin, India became the third country in the world who started manufacturing own insulin after US and Europe. So thank you very much for all the doctors for giving support and guidance towards Vosulin. One more great news is there, sir, that we have launched a new and improved MyPen 2, which is basically an insulin delivery device. And this device is designed in Europe and it is ISO 11608 approved, sir. So allow me to share a very brief video with all of you, which will depict the features of MyPen 2. So here's the video, sir.
Doctor, good quality insulin pen, which is intuitive in nature and easy to use, plays an important role in insulin initiation, adherence, and better patient outcomes. Addressing these needs, Wockhardt proudly presents MyPen 2, which is designed in Europe as per ISO 11608 standards. The salient features of MyPen 2 are improved design. MyPen 2 is sleek with a soft touch cap and smooth finish body. MyPen 2 has a twist lock cartridge cover for ease of replacing insulin cartridge. The dose delivery is smooth and easy, ensuring less pain and discomfort. Loud and audible click sound in MyPen 2 ensures error-free dose delivery. Easy to use. MyPen 2 is easy to set, easy to read, and easy to inject insulin device. Its light, sturdy, round, non-slip body ensures maximum grip which helps in smooth administration of dose with confidence and convenience. Usability features of MyPen 2 like low force to inject and easy cartridge replacement ensures better acceptance by all age group of patients. Accurate. MyPen 2 is designed in Europe as per ISO 11608 standard and manufactured in India as per ISO 13485 standard. MyPen 2 shows excellent dosing accuracy at all dosage levels. Even the injection force is comparable with best-in-class devices. MyPen 2 can be used with Claritis and Vocilin range of cartridges. Doctor, kindly pass on the advantage of improved, easy to use and accurate MyPen 2 to all the patients on Claritis and Vocilin.
So thank you very much for watching this video, sir. And this is the pen that we have launched recently, and now it is available in the market. And I'm sure that once you use this pen and give it to your patients, you will definitely going to feel a difference. So now I hand over the session to Ravi for the vote of thanks. Thank you very much.
Thank you, Vishwa. I would like to thank Dr. Gautam for accepting our invitation and being a speaker for this webinar. Thank you, sir. And also I would like to thank Dr. Sugan Goel for her excellent moderation skills throughout this webinar. And I would like to thank our IBB head, Mr. Amrut Medekar, sir, and our AVP, Mr. LCS Vishnu, sir, for their continuous guidance and support for conducting these webinars every week. I would also like to thank all my HO colleagues and the field colleagues who are working very hard for making this webinar successful. And lastly, I would like to thank all the participants to take their time on the weekend and present with this in this webinar. So thank you, everyone. We are logging off now, and stay tuned. We'll see you soon next week. Thank you.
Thank you very much.